on Young Leaders Panel, and then that will be followed by the session on psychological injury in cancer care, and then the Global Public Forum. So we are making a little adaptation so that we can finish at a reasonable time. Sorry, apologies for the program going a little longer than we expected. With that, I will ask Dr. Issa to come up. Dr. Issa, your session. Yeah, so we'll finish up. Yeah. So maybe if you.
Good evening. We will be very fast because of the sake of the time. This session will be about young leaders, entitled with Next Generation Voices, Challenges and Opportunities in Cancer Care across the AMSTRO region. This is going to be a multidisciplinary session. In this session, we will have radiation oncologist, surgical oncologist, medical physicist, as well as medical oncologist. So I will call the first speaker. Dr. Elaf Wael is a resident in surgical oncology from UAE. Please, Dr. Elaf.
Okay, I'll try to be as quick as possible since most of the things were already mentioned and discussed earlier. To begin with, good afternoon, everyone. My name is Elaf Abazid. I am a surgical resident in Tawam Hospital. Thank you so much for having me. It is my absolute pleasure to be here today. The topic, as said, is about the challenges and opportunities in cancer care across the AMSTRO region from a young physician point of view. So to start with, it was already mentioned, and we know by now why are we discussing this. Despite all of the efforts put into cancer care, we still face cancer being one of the most leading causes of morbidity and mortality worldwide. And it was shown earlier how the cancer burden is actually increasing. Speaking numbers, in 2018, the newly diagnosed cases were 18 million. In 2020, 19.3 million. And then in 2022, it was 20 million newly diagnosed cases of cancer. The WHO is expecting this number to increase up to 35 million newly diagnosed cases annually by the year 2050. And this is attributed to the population growth, the aging, and the increased exposure to risk factors. And this also, not only worldwide, the AMSTRO region reflects on this increase in the incidence, which is why, as younger generation, we need to be more prepared. Now, before we talk about the challenges that we are facing, we need to know how the care is actually provided in the region. Already it was discussed in more details. However, we follow in the AMSTRO region the multidisciplinary approach when dealing with cancer. The care is concentrated mainly in the tertiary hospitals in major cities, and then the referrals come from the peripheral hospitals. We prioritize the diagnosis and the treatment of cancer cases. However, we also provide follow-up and survivorship care that is a bit less standardized than the diagnostics and the treatment for the patients. Now, I can speak more about the UAE since I practice here. In the UAE, the cancer care is, I believe, advanced. From what I've seen so far, we depend heavily on the multidisciplinary approach. So we tend to have weekly, if not more, of meetings, tumor board meetings, oncology, radiology, pathology, and surgery. We discuss new cases, and then we finalize plans sometimes. Another thing is that we are lucky to have advanced radiotherapy centers with modern technologies. Some oncology centers, they provide the patients with targeted or tailored therapies, depending on the genomic profiling that is being done. We have structured supportive services for our patients. And when it comes to palliative care, we provide them with psycho-oncology, we provide them with counseling, dietitian help, and pain management. We've seen recently how the awareness has risen a lot in the area due to the efforts put into the campaigns for awareness. And finally, the UAE National Registry of Cancer helps allocating resources and also guiding the care delivery in the region. Now, speaking about some of the challenges that we have seen or we see as junior physicians on the ground in real life, late presentation remains to be one of the most important challenges. And this limits the treatment option that we can provide for our patients in areas or in countries that the treatment options are already limited. Another thing is the diagnostic barriers and the variation and the treatment access. These are all because of how variable it is or how widely it varies in the region between one country to the other and sometimes within the same country. Another thing is the fragmented care coordination. The patient goes through multiple specialties before reaching the final destination, and this should be coordinated more in order to save time and to limit the loss of follow-ups. Another thing would be geographic and logistical barriers. And this is because we said we depend on tertiary hospitals in major cities. Patients tend to have a problem with travel distances or with finding appointments. And sometimes also insurance might play a role in delaying care. We have seen how we lack a bit when it comes to data. We need more research in order to fill this gap in the data and to have clinical trials with outcomes, real-world outcomes for our patients. All of these challenges were already taken into consideration, as we've seen earlier, in the planning, which is something that we are proud of. Some of the solutions that could be added, simple solutions, would be to have diagnostic bundles that are pre-approved by the public or the governmental hospitals, private hospitals, and the insurance companies. So we limit the repetition of imaging and the repetition of any tests necessary. Another thing is to have a standardized referral pathway and triage system. So with urgency tiers, so the patients can be dealt with easier. Tele-MDT and regional MDT is helpful when it comes to discussing new cases, interesting cases, and sometimes to share mistakes in order to innovate and fix. Another thing would be to something simple, just like timestamps or timelines. So we can have a standardized timeline between where the patient first appears with a symptom or present with a symptom, and then the time the patient gets a referral. And then from the referral to the diagnostics like imaging or biopsy. This might limit the loss of time for the patient and for the treatments. Now, as younger generation or younger physicians, why is it important for us? I would like to emphasize something that was said earlier, how cancer care or the future of cancer does not lie only on the technology. It also lies on the manpower. So as clinicians, we go through the journey with the patient. So we need to be more prepared. How can you empower us as the next generation? Is by having a structured mentorship and leadership roles to be involved earlier in MDTs, clinical decision-making, to have hands-on exposure to system-level challenges, planning, and policy. And in order to be competent enough, we need access to education, research, and innovation, which is being actually provided for us now. All of this cannot happen without having a supportive work environment that teaches us how to communicate clearly, how to verbalize our thoughts, and to be able to innovate together. Now, in conclusion, we have many challenges. However, they give us tremendous amounts of opportunities for research, trials, for improvement. We see the improvement already, but we might need to work harder. Another thing is that as a junior doctor, I believe in order to be more prepared for the better future, we need to be more involved in the present now. And by that, I end my talk. Thank you very much for listening.
Thank you, Dr. Elaf. We will keep the question and the answers to the end of the session. You are an example of a motivated surgeon, and I am sure that in near future you will be a leader in your surgical oncology field. So now I will move to the next speaker, Dr. Fatima Shaukat. She is a radiation oncologist from Pakistan. Please, Dr. Fatima.
Assalamu alaikum and good afternoon, everyone. It is my honor to represent my region as a young oncology faculty member. Today, I'll be sharing the real challenges we face in LMIC in Pakistan as a young faculty, and most importantly, the locally driven and scalable solution we have devised based on the limited resources. I've structured my presentation based on a simple framework known as CART, comprising of 4 components: clinical, administrative, research, and teaching. Coming to the first component, the clinical challenges. The clinical challenge we face in LMIC in Pakistan is time and access. We have limited machines, long waiting in the machines, and high patient load, especially of the complex diseases of head and neck cancer, rectal cancers, and breast cancer patients. And the risk is very evident that treatment window may be missed. Our solution was to redesign the workflow and not to wait for more machines. We introduced pre-operative and pre-cycle booking system with the collaboration of surgeons and multiple multidisciplinary tumor boards. Now patients come with official letterhead of surgery showing the date of surgery. We pre-book them for the radiation slots for head and neck cancer in the 4th post-operative week, and we ensure that radiation is delivered within the span of 6 weeks of post-surgery. For breast cancer patient in our region, due to long waiting, we book them on the 2nd or 3rd cycle of AC. And for rectal cancer patient, we book them in the early protocols of TNT cycles. In parallel to this, we have strengthened our public-private partnership because Pakistan is a major hub of philanthropy, but the impact depends on the wise, timely, and transparent utilization of fundings. Administratively, administratively in LMIC, oncology has a fragmented system because of the lack of structured multidisciplinary care, limited platform for the networking, limited leadership and mentorship opportunities. To address this issue, we locally created a society known as TEF. TEF is a student-run initiative to organize and conduct tumor boards in a tertiary care setup. Till now, we have formed 4 different chapters. TEF not only provides leadership opportunities, but also provide oncology familiarization, networking, research, and education skill building to young oncologists and also medical and undergraduate medical students. TEF now serves as a model, as a blueprint for a viable solution for multidisciplinary care in LMIC. Globally, we have created Global Village Oncology Network. Javon connects cancer professionals across border to share knowledge, best practices, and training. We have created multidisciplinary pods, site-specific pods, which identify the gaps across the globe and across the border, where people, the young oncologists, share knowledge, research, clinical care, and implement systematic solutions. Official website was launched in January 2023, which also anchors this global exchange. Coming to the research component, research is again facing a major barrier in LMIC, especially in Pakistan, because of limited cancer registries, scarce resources, and few cancer sites, especially the head and neck, is very different in our population and needs a tailored treatment because the biology is different from the Western population. Despite of these challenges, we are able to produce multiple publications in highly indexed papers, and these are even done at the residency level. Not just these, we have also published numerous books with registered ISBN number. This is an example of one of our books published by Curie Sisters for the management of head and neck cancer patients, because the biology is different in our region. Understanding and the tailoring treatment for head and neck cancer patients, this special book was generated in our own country. So the impact is not just local, we have a global impact as well. Despite of limited registries and scarce resources, we have produced 2 of the trials which are recently selected as a global impact So last year in the Accurate Exchange program, a phase 2 randomized controlled trial comparing whole breast radiation versus partial breast radiation using extreme hypofractionated regime was selected as one of only 2 winning trials globally. And another trial on verbal instruction versus simulation video education and radiotherapy, a randomized controlled trial for LMIC, is awarded as the best oral presentation as AMSTRO, which will be presented tomorrow. Coming to the teaching component, teaching is another challenge in our region, and we as a lifelong learner always love to add something to our learning curve. The online upgraded courses at ISTRO and ASTRO are excellent but expensive and often require additional charges for our top-ups of young faculty. So we created our solution. We designed a model known as KIPRO. KIPRO is basically a club for young Pakistani radiation oncologists. We conduct online sessions which are free of cost. We also contact the authors of major trial and we discuss our learning objectives with them. Till now, we have conducted 13 educational sessions. All these sessions are available in a recorded version or on a YouTube channel. Our second model is meta-campus model, which is a multidisciplinary model, which conducts same session, but not related only to radiation oncology, but also of medical oncology, surgery, and other specialties based on our specific learning objectives conducted by subject experts. So on conclusion, with limited resources, but unlimited commitments, LMIC are not just adapting global models, we are creating our own. And CART is not just a framework, it's a call to action. And this is how next generation leadership looks like, from local to global impact. Thank you very much.
Thank you, Dr. Fatima. Actually, she is an active AMSTRO member. She did a lot of works and she organized a lot of things in this conference. Now we will move to the third speaker, Mr. Mohammed Al-Ghaferi. He's a medical physicist. He will speak about the obstacles and opportunities in Oman.
Hello, everyone. Good afternoon. Thank you for the invitation and for letting me speak here in this meeting. My name is Mohammed Al-Ghaferi. I am a medical physicist at Sultan Qaboos Comprehensive Cancer Care and Research Center in Oman, Muscat. In this short talk, I will be presenting from the perspective of an early career medical physicist who is working in the AMSTRO region. It will focus on the real world clinical experience, what we face, the challenges every day, the problems, and offer some solutions to solve them. So across the AMSTRO region, there is a rapid expansion of radiotherapy services. Now there are many centers that have modern linear accelerators, modern LINACs, modern state-of-art imaging devices, and increasingly advanced treatment techniques. At the same time, there is also a large variability between the centers. And this variability in terms of the staffing levels, in terms of the resources, and in terms of the experience level as well, clinical experience. Also, one can note that this region has a young workforce, but this young workforce has a limited mentorship, and that affected their learning curve. Also, we are working under high patient load and limited time for improvement. And when an improvement is made, it has to be made under the pressure of clinical work. So to speak about the challenges, the key challenges, one is the main challenges is that technology does not equal expertise. Modern techniques or modern equipment, like modern techniques like SRS, SBRT, and adaptive radiotherapy, they are taking time and experience to learn them. So they are increasingly available, but it takes time to the experience to use them safely and effectively. It takes time to development. Another challenge is the limited of QA standardization in the region, such that we have similar devices in this region, but there is no shared QA protocols such that it will provide a reference for us in this region, because we have our own demographics and we have also our own resources. So we have to adapt new in my opinion, new QA protocols in our region. Also, there is the medical physicists are usually working under complex workflows, which has also, they are working under time and resource constraints. So some of the practical solution and opportunities, first from the perspective of a medical physicist, one can say that we should start a regional protocol harmonization, such that the centers in this region they have something in common in clinical practice, whether for patients or whether for the QA as well. Also, another area of improvement will be the smart automation of QA and reporting. This will leave us some room for other development, for more demanding and for more demanding clinical tasks. Also, structured mentorship networks within the centers and between the centers in this region might help the young workforce, the young medical physicists or the clinicians to have experience in what they are doing. Also, regional training and case sharing between the centers, so such that the centers will not work in like an isolated islands. They should share their experience with others. They should learn from each other. So lastly, the role of the next generation is, in my opinion, we should act as the operational link between technology and clinical delivery. Also, we have to ensure the continuity of quality across evolving clinical practice in terms of whether in the equipment or the new protocols for patient care. Also, we support reliable treatment delivery under increasing workload. Also, help establish shared standards of clinical practice region-wide. And thank you very much.
Thank you, Mr. Mohammed, for highlighting the opportunities and obstacles that you face in cancer care in Oman. And now we will move to the last speaker, Dr. Yara Alkanash. She is a medical oncologist, will speak about the opportunities and obstacles in medical oncology in UAE. Thank you. Please.
Okay. So good afternoon. It's truly an honor to be here today. And I would thank AMSTRO organizing community for giving me this opportunity. So I will be here for speaking on behalf of actually early career medical oncologists working within the unique realities in our region in cancer care. So why this topic matters? Actually, cancer care, now it is a very important topic, and we have really a lot of challenges, and it is at a critical crossroads in our region. So, as mentioned before, we are dealing with rising cancer burden as well as late-stage presentation, along with younger patients' presentation incidence is getting higher, as well as wide diversity of healthcare resources with rapid adoption of novel therapies in some areas versus limited access in others, with high patient volume as well as increasing workforce pressure. So our perspectives as young oncologists, balancing clinical training, service delivery, research, and career development, as well as commitment to lifelong learning, along with transitioning from a trainee to an independent clinician and developing a professional identity, managing the emotional impact of cancer care while remaining compassionate and resilient. Also, another thing is building confidence while navigating clinical uncertainty and shared decision-making. We truly have challenges that are not theoretical. Those challenges shape how we train, how we practice, as well as how we envision our future in oncology. So coming to clinical challenges that we face usually manifest by significant disparities in access to diagnosis and treatment that affecting outcomes and the quality of care. Also, we have heterogeneity in healthcare resources as well as rapid adoption of new therapies versus limited access in some areas, along with limited access to clinical trials, variability in guidelines, implementation across the region. Coming to the professional challenges we have, first, high patient volumes as well as limited subspecialty training opportunities, along with limited protected time for research and academic development. Coming to system-level challenges that we face, including limited oncology infrastructure in some countries, with unequal availability sometimes of modern therapies, including targeted therapies or immunotherapy. Each challenge has a solution. So starting with the practical and regional solutions, we look for strengthening regional collaboration and the tumor boards, development of adapted resource stratified clinical guidelines, expansion of multidisciplinary care models, including tele-oncology, virtual MDTs, and growth of virtual education, mentorship platforms, as well as encouraging fellow-led research, audits, and quality improvement projects. Opportunities are ahead, and with the presence of strong regional societies like AMSTRO, as well as a motivated and growing oncology workforce, expansion of digital health and tele-oncology, and increasing regional research capacity with implementation of precision medicine and biomarker-driven therapies. What needs to be prioritized? Actually, investment in oncology training and education, support for locally relevant research and region-specific research, policy advocacy to ensure an equitable access to cancer therapies, empowering young oncologists in leadership and decision-making roles. In conclusion, cancer burden is rising, but outcomes can improve. Addressing disparities requires regional collaboration, and next generation oncologists are key drivers for change and will play a major role in shaping the future of cancer care in AMSTRO region. By this, I would thank you all for your attention. And just one thing, empowering an early career oncologist, it's not optional, it's essential for the future of cancer care in our region. Thank you.
Thank you, Dr. Yara. Now, Dr. Hiba is going to handle the question and answers and to conclude the session. Dr. Hiba.
Hello, everyone. I would like to extend my heartfelt appreciation to all the speakers who so eloquently discussed the challenges among the young oncologists in the AMSTRO region. Your perspective brought clarity to the struggles we face daily in the clinical practice and training. So thank you for the valuable contribution. So do we have any questions from the audience? Yes, please. Can you please hand over the mic?
Good evening, everyone. Assalamu alaikum. I'm Dr. Yasmin. I'm a radiation oncologist from Apollo Cancer Center, India. So I have a question here. So my question is, like, all the day through, we have discussed so many things regarding, logistics and how late presentation is an issue here. So I have not, like, somewhere I didn't see anyone focusing on the fact how to cut short the time from the diagnosis to the initiation of treatment. And I think in this region, some of where it's not the lack of, facilities on times, because being a country like India, Pakistan, or Bangladesh, even though there are lack of resources, but the clinicians' eyes are very precise. So I believe how to shorten the time from the diagnosis to the initiation of treatment. And second question I'd like to ask is, since we come from a society where 15% of our females may be very independent to take a decision, most of us, okay? So instead of, we are making obligation of screening and all. So don't we think it will be more useful to educate more than the females, the males as well? Because we come from societies where many times it's the male who takes the decision even for the biopsy to start off the treatment for the patient. So these two
Thank
questions.
you.
Thank you.
Okay. Thank you, Dr. Yusra, for your question. So yeah, definitely, you are highlighting the exact reality of the society. Definitely, where in earlier session we were discussing regarding the difficult times for the patients as well as their families when they are receiving the treatment of the cancer. But on the other hand, as a young oncologist, I think that we also face some challenges. For example, you are highlighting that the time from the diagnosis till the treatment is like long time, and usually patient lost to follow up due to this gap. So yeah, this is the thing that we need to to solve it. And this is why we conducted this AMSTRO region, so that we collaborate and find the solution to these problems. I hope you got my answer. And due to the shortage of time, I just call upon the stage the next chair, because we are already running out of time. So Dr. Sadisha Abrar, please come upon the stage. Oh, okay.
I just wanted to follow up on what you said just now and the question from the lady from the Apollo Center. I think, we forgot to call out about the importance of oncology nursing. Oncology nursing in the States and in Northern Europe has reached such high level of training that they can, release a lot of time for the oncologists themselves. They can take up a lot of the work done that we do in our centers here, whereby the doctor takes from A to Z. Oncology nursing abroad, the nurse is almost a doctor. And I remember when I went to the US with my son, first time, I was met by this nurse practitioner. And we had the meeting and so on. And then she said, okay, see you next week. And I said, typical low middle income mentality. I said, wait a minute, but where is the oncologist? And then lo and behold, later on, I realized that, we will see the oncologist, but we didn't need to see the oncologist day in, day out, or every week necessarily, because the nurse practitioner was so highly qualified about the side effects, the routine things. She got to know us as a family very well. And that is something where low middle income countries, we need to update and work more closely to empower nurses beyond being just assistants and helpers, actually empowered to make decisions in oncology as well, up to the point that they can with their education. Thank you.
Exactly. Dr. Sadish? Dr. Sadish Abrar, would you please, okay.